thanks very much, ladies, for giving us your time this afternoon. And just for our benefit, can I introduce Christina Dyer, Christina is the lead breast care nurse for Doncaster and Barcelona Teaching Hospitals.
Yeah.
And Claire Rogers, Miss Claire Rogers, who is consultant breast surgeon. So thank you both for your time today. We really appreciate helping us on this project. Are you okay if we just do a question and answer session?
Yes.
Yeah. So the first thing I want to ask you is, could you tell us about when we should seek help when we are concerned about breast cancer?
So it really depends upon your age. So women who haven't gone through the menopause often get what we call cyclical breast problems that seem to build up before a period and settle with a period. So what we would say for premenopausal women, any new lump, any lumpiness that seems different on one side from the other, skin or nipple change which persists for more than a week after the start of the period, is something you should see your GP about. If you're not having periods because you're taking, say, a contraceptive pill that stops your periods or something like that, it's really any change that persists for more than 1 month. If you do have a change which disappears completely, then you don't need to worry about it. If you, after the menopause, any new lump, lumpiness, skin or nipple change could be of concern, so it is right to see your GP as soon as you can. Now, there are other conditions that are less worrying. So in any woman, if you get a combination of redness, pain and swelling, it's usually an abscess. Now GPs are great at treating abscesses, so see your GP as soon as you can. Occasionally redness and swelling can be a sign of something more serious, but GPs are experienced at examining breasts and they would know when it's something serious and needs referral to the breast clinic. If any woman gets more than one episode of fresh blood coming from the nipple, that is a reason to see the GP. And also if discharge from the nipple becomes on a regular basis out without squeezing the nipple, so in other words spontaneous discharge, then that's a reason to see the GP. Another reason might be if the breast shape seems to distort, not as a one-off but as a kind of an ongoing thing. We often get patients coming with pain. Now pain alone is very rarely a sign of cancer, and that should be reassuring. Most breast cancers are painless. Severe pain is virtually never the first sign of cancer. If there's severe pain, then it's cancer. It's usually associated with other symptoms, say a lump or something like that. In premenopausal women, most breast pain is caused by the hormone cycle. Usually it will settle after between a few weeks and a few months. Sometimes it will take more than one cycle to settle. In postmenopausal women, most breast pain actually comes from the chest wall and not from the breast itself. So the patient feels it in the breast, but the actual source of the problem is something like wear and tear, perhaps in the spine, the ribs or the shoulders, or sometimes a torn muscle, something of that sort. It is safe to use simple painkillers and a soft bra if you have pain alone. Obviously, if it doesn't settle, see your GP. Some changes happen in the breast very, very gradually over a long time. So things like slow drooping of the breast as you get older. If you've got, say, a nipple that's a bit inverted and it goes a little bit more in, but it's very gradual over a long period of time with no other symptoms, then that wouldn't be worrying either. But if you have a more sudden change, then you should see your GP.
Thank you. Can you tell us how we should seek help when we are concerned about breast cancer?
So if you're just not sure about your symptoms, a really good place to look is the Breast Cancer Now website. Breast Cancer Now have lots of information for patients, and that includes information about conditions that are nothing to do with cancer. So it can be very reassuring. They have leaflets on things like pain, nipple discharge and other conditions that are not worrying. If you're still concerned when you've looked at the information, do see your GP. GPs are trained to look at breast problems. One place we would suggest you don't go though is A&E, because the doctors aren't really trained in assessing breast conditions except for breast infections. A&E doctors are very good at treating infections, but they're not really very good at treating other problems, so the GP would be the first place to go.
Can I ask you about the number of referrals to secondary care in Doncaster?
So we're referred around about 100 patients a week to the clinic in Doncaster and about 40 a week to the Bassetlaw Breast Clinic. These patients are referred either urgently because the GP thinks they might have cancer, or because they've got another problem that we usually try to see people within 2 weeks, but it would be less urgent. Problems such as maybe a bit of lumpiness or pain, something of that sort.
Gosh, that's a lot of referrals you're dealing with every week.
Yeah.
Has the pandemic impacted on your referrals?
I think we were quiet for a little while, wasn't we? As the patients or our ladies in the community were sort of encouraged, the population not to bother the NHS as such, and they were sort of guided. Not that the GPs wasn't seeing face to face there, so our clinics did become quiet. We were still seeing though some patients face to face, so our service never completely stopped, like some parts of the hospital. And it's picked up quite a lot recently, so we're having to put extra clinics on to catch up.
With the backlog.
Yes, yeah.
It's helpful, thank you. Of all these patients that are referred by GPs, how many of them have a cancer diagnosis?
Well, the good news is that less than 10% of people referred have a cancer.
Oh, that's
So
very
it's low
reassuring.
numbers.
And in fact, 85% of people will be discharged after the first visit. So that's very reassuring.
It is, it is. I don't think ladies know that.
No.
How many ladies referred from the screening service go on to have breast cancer?
About 25% of patients with cancer were referred by our screening service, and that's here at Doncaster and at Bassetlaw. The reminder was to refer, or the rest of them was referred by the GP with symptomatic problems there. So last year we had, bear me with numbers, 18,566 women attended breast screening at Doncaster and at Worksop, and 135 women were diagnosed with a breast cancer. So sort of percentage wise it's low, but it's really numbers game. The more we see, the more we can sort of detect cancers very early and smaller. So screening doesn't stop us getting breast cancer, it detects it at a smaller, earliest stage.
That's reassuring,
Yes.
that number of
Yeah.
ladies. Is it just ladies that have breast screening?
It is,
Yes.
just
Yeah.
ladies, yes.
Yeah.
Can you explain what the 2-week wait referral to the breast clinic means?
So what that means is that the GP thinks that you might have cancer. It definitely doesn't mean that you do have cancer. In a few cases, the GP will be fairly sure that the person does have cancer, but most of the time it's just they have a symptom that means it could possibly be cancer. In other words, most people who come under a 2-week wait appointment don't have cancer. We just want to be sure.
Right. So will you actually be seen within 2 weeks if you're referred by that process?
We try very hard to see people within 2 weeks. Right now we're just about managing to do that, but we have had extra clinics to bring the weight down. Women who are referred on the what we call the breast symptomatic route ideally should also be seen within 2 weeks, but at the moment the waiting time is 4 weeks due to high demand, but we are trying to get that back down to 2 weeks.
So in normal times is that 2 weeks?
In normal times it is 2 weeks.
That's good. Can I ask you about the outcomes from breast cancer in Doncaster?
So the women, the percentage of women that actually are diagnosed with a breast cancer, and that's through symptomatics or breast screening, a high percentage, about 85%, we sort of look towards curing.
Right.
And sometimes we'll say that word in consultations, and so survival of that 5 years is quite high.
So if you turn up at screening and you get symptoms on screening, when you come to the hospital, 85% of the people that actually come through the hospital will survive with breast cancer.
It is, and so much so that we get them past maybe their first breast cancer, and I know this not to sound negative, but we get them into old age, that they might develop another breast cancer that's not connected to their first diagnosis there.
important breast screening is.
Absolutely.
And or self-examination.
Yeah.
From breast screening, just to mention, mammograms aren't 100%, because there's a different types of breast cancer. There's a family of breast cancer. So the most common type, invasive ductal cancer, can be seen because it causes smaller, harder lumps. The next type is invasive lobular. Doesn't mean it's more aggressive, it's just a little bit trickier to detect. And when we compress the breast, we can squeeze out the milk sacs where the cancer cells might be. And so when you get a letter to say that it was okay, no cancer detected, the woman must still keep examining herself, and then it changes 4 weeks, 4 months, a year later. From a normal mammogram, they must still report to the GP and be referred into the Jasmine Centre to be fully assessed there.
Right. At the hospital, what would happen when I came to the Jasmine for an appointment?
So the first thing you'll do is you'll check in at the reception desk, have a seat, and when we're ready for you, one of the nurses will take you through to a clinic room. One of the doctors or nurse practitioners will come and see you, and they'll start by asking you a whole lot of questions. Then we'll do a full examination. Now, at that point, some patients can be given full reassurance that the problem is not serious and they don't need any tests. So some people are actually discharged at that point after only sort of 10 minutes or so. But some people need to have some more what we call breast imaging, so perhaps a mammogram or an ultrasound scan, or sometimes both. So what we do then is we give the lady a gown, or they can bring their own dressing gown if they prefer, and we take them round to a second waiting room, which is just women only. The doctor who's seen, or nurse practitioner who's seen the patient, will write a request card, and then the radiologist will decide if that's appropriate and will arrange the best test for that person. Normally speaking, over the age of 40, you have a mammogram and an ultrasound scan, and under the age of 40, it's an ultrasound scan only. But that can vary if the radiologist thinks that we say you need an extra test or you don't need a test. If you've had a mammogram very recently, that will be a reason for not having a mammogram. Now, if they see something on the breast imaging, what they usually do is they then proceed to what's called a needle biopsy. So that involves using some local anaesthetic to freeze the skin, and then they use a special needle to take a little bit of a bite out of the lump or whatever it is they see, and that gets sent off to the lab. Now, because that takes time to analyse, it means that we can't give a result that day. So in that situation, we would need to call you back for the results, or sometimes we can give the results over the telephone. Once all the breast imaging and biopsies are finished, then the patient is brought back round to the clinical room, and the doctor or nurse practitioner will then just see them to explain what has been found. Obviously in some cases we can reassure and discharge. In other cases we'd make a follow-up appointment. We haven't talked about men much, but men usually don't need breast imaging. In fact, often they don't need anything other than a blood test.
So for lots of ladies, they'll know they've not got breast cancer after the first appointment.
That's right.
Yeah.
And for those that may have breast cancer, they'll know that if they've got cancer within a few weeks. Is that?
It's within a week.
Within a week.
Yeah.
Within a week.
Sometimes at the first appointment we can give a very good indication, because in some cases it's so obvious from the examination and the imaging that it is cancer, and we are honest with ladies. We don't hide anything from them, because people need to understand and know what's happening to them, and it helps them prepare for the next visit if they have an idea what's happening. Equally, if we know it's very unlikely to be cancer, we would assure somebody, because we don't want them worrying unnecessarily.
Can I bring somebody with me if I had to attend? Could I bring someone with me?
Yeah, so what we're doing at the moment to reduce the risk of COVID is, where possible, we want to have people in the room on their own for the first appointment for the assessment. But if people need any assistance, say an interpreter or a carer, something like that, then of course they can have somebody with them. When we give results, we are happy to have somebody else in the room, because we understand that when we give results and explain treatment, it's quite complicated, and it really helps to have a friend there.
And not everyone will ask, where can I park?
We would strongly recommend using the Park and Ride, which has just been resurfaced, and there's a lovely bus to bring you up to the South Block outpatients. It's a very simple walk through the South Block outpatients to there's some lifts and stairs at the back, up one floor, and the Jasmine Centre's right there.
And who would I meet? Who would I meet?
Well, you come to the receptionist first. Once they're ready for you in the clinic, usually a healthcare assistant or staff nurse will bring you through into the room, and then you'll meet a doctor or nurse practitioner. When you go around to the breast imaging, you'll meet a radiologist or a radiographer.
At the appointment, she sort of said that she was very distressed, her husband was with her and she left. Would you, obviously what would happen then if she's just left? Would you follow up and try to make another appointment, give her the same
Absolutely.
opportunity to speak again?
Absolutely,
You know?
we would make another appointment for face to face, but if that person wanted to talk over the phone, we would be able to do that. If people want to talk about things over the phone, particularly if it's news of a more sinister nature, we try to organise that they've got somebody sitting with them, because it can be quite distressing having bad news over the phone, and that's not our preferred way of giving it, but we know that for some people that does work better.
Had it in the past where if we've had somebody that struggled with breast screening, or we do the family history, and if a patient's been to the geneticist service and they've picked up that they struggle with hospitals, sometimes we, as breast care nurses, we can ring and start that discussion and explain, like we're doing today, about who you would meet, would I be there to meet them, and talk them through on the understanding if it's overwhelming and they want to leave, we would allow them and just keep giving them opportunities to attend.
Would you have a designated nurse if you've got breast cancer?
So yes, so on the diagnosis or through breast screening, the breast care nurse, or sometimes we're called clinical nurse specialist, we're the key worker, and so we try our best to be in the room when the consultant is giving the diagnosis. It's more to hear exactly what the doctor has said to the patient with the diagnosis, and it's actually to read what the patient or relative is actually, how they're reacting to the news, so you can support them better, because we can see people struggling sometimes with medical information, or rightly so, coping mechanisms, or if they have to switch off at certain points, so you know we haven't got the full information to them. And as a breast care nurse, we try then to arrange a meet-up with the patient and the relative a few days later to go over the diagnosis again. So it's not telling them anything new, it's the information that was already given, and add any other information. So we sort of do holistic needs on the patient that day when we meet up a few days later, to listen to their concerns and any bad experiences that they've had with cancer pathways, with relatives or friends, or themselves if they've had a cancer diagnosis in the past.
A lot of patients tell us they shut down.
Yes.
Like that, they just can't, they're overwhelmed by that information.
Yes.
So that's reassuring,
Yes.
because you know, they can then come back and speak to the breast care nurse that's been in the room. That's
Yes.
yeah.
So we try our best to keep the same breast care nurse, but sadly, for due COVID time, sort of say illnesses or anything, but we work as a team as breast care nurses, so we'll support as a team the patient and relatives through treatment.
If the patient wants to get in contact with you between appointments, are they allowed to do that?
Yeah, so when we first meet, there's information booklets we give, but we also give a contact card. And on that, because we're cross-site cover, so we're at Doncaster and we're at Bassett Law Hospital in the breast unit there, so we've got numbers for both sites. And we always apologise, but we have an answer machine, so we always encourage them to leave their name and number, and because we're not office based, so we're in and out the office throughout the day, and we're retrieving messages constantly and try and get back to them later that day, if not the following morning.
That's great.
The other thing we do is we copy patients into the letter we send to the GP, and sometimes we'll do a special letter for the patient to explain if they've asked for that. But the difficult thing for the doctor is trying to explain it in words that are the patient will understand. It can be quite hard to gauge what the patient understands of what we've said. So what can be very helpful is the breast care nurse can actually help effectively translate that letter, and so it makes more sense for that individual patient.
What are the possible treatments and advice if I do not have breast cancer?
Most conditions that are not quite cancer don't require treatment. What we do is we give some very specific advice about that problem. We often have patient information to give out as well. A few patients are advised to have surgery. That might be something, for example, like it's a breast lump, it's not cancerous, but because of the size we might recommend it's removed so it doesn't cause a cosmetic problem. So we would explain all of that, and we usually book that all at the same visit as well.
And what about what treatments could I expect if I do have cancer?
So most cancers are treated with surgery. Some patients also require tablets, and we call that hormone therapy. And some patients also need bone strengthener called a bisphosphonate. About 2/3 of patients will need radiotherapy after their surgery. Few will need chemotherapy, and in some cases chemotherapy is actually given before the surgery. So generally speaking, it's usually surgery, chemotherapy if you need it, then radiotherapy and tablets. But in some cases it's chemotherapy first, then surgery, then radiotherapy and tablets.
Christina, will you tell me a little bit more about chemotherapy treatments?
Yeah. So chemotherapy treatments, chemotherapy means drug treatment. So it's still a drug treatment, but usually when we're giving it to a primary breast cancer patient, a lot of it involves drips. We can give most of the treatments here in Doncaster, and we use the Chatsfield unit, so we're not automatically travelling to Sheffield, which we used to do many years ago. We're under the care of a different team, but we're called the oncologists or the cancer specialists from Western Park, but they come to see our patients here in Doncaster. So we try and keep everything as locally as possible. Chemotherapy is for patients, their worst fear is hair loss, and the types of chemotherapy we give in the early stages to prevent breast cancer coming back does affect the hair follicles. So majority of women will lose their hair, but we will counsel them about sort of wigs, and when COVID's over, hopefully we can go back to scalp cooling so we can try and preserve some of the hair. And we usually work with the Aurora Centre from the Headstrong point of view to look at scarves and alternatives to that. The other fear that patients have with chemotherapy is about sickness. We've got much better over the years about dealing with sickness. We've got very strong anti-sickness drugs, and we use a combination, and it's very individual to that lady, and we assess them every time they come. It's usually every 3 weeks, but we check how there was the last cycle of chemotherapy, and we can adjust either the regime of chemotherapy or the drugs to support the patient and have probably a better experience with that next cycle there. So we keep close eye on the patients. The things that doctors and nurses worry about when our patients are on chemotherapy is them getting infections. So we give them advice about, and it sounds really sad at the minute, but COVID's helped for our ladies on chemotherapy because we're wearing masks, we're washing our hands more, so we're keeping these patients safer as a general public. And we give them constant sort of advice, and we're encouraging them to ring for advice either for the breast care nurse, but we'll guide them either to the Chatsfield, the chemo unit, because they're the specialist nurses that know the drugs that they've given, and there's a 24-hour sort of a hotline to Western Park where it's manned day and night. And lots of times ladies, when they first start chemotherapy, they're very anxious. They can ring even if it's 2 o'clock in the morning, or a relative, a partner that's supporting the patient, and get advice. Most of the time it's reassurance and explaining that these are side effects and they'll pass. If we're worried about that patient, they'll liaise with the A&E department or medical assessment, and we'll advise that lady to come to the different departments for a blood test. And majority of times we can just see that they can cope with this minor infection and give them some oral antibiotics. If they've struggled a little bit, a few ladies need to be admitted overnight or a few days for quite stronger antibiotics through a drip. But majority of women, when they go on to chemotherapy, they're managed at home. They only come for their treatment on one day, and majority of the regimes is every 3 weeks for maybe 6 times. So most of their care is recovery at home. They're not always in that hospital setting.
Can you tell us a bit more about radiotherapy?
Yeah, radiotherapy we give to women when we've conserved the breast, so that's more likely to have radiotherapy. The only problem with radiotherapy for our Doncaster patients and Bassetlaw patients is we still have to send them to Weston Park, but we have the Firefly if we've got any transport issues within both areas to get them backwards and forwards. Radiotherapy involves X-ray treatment, so rays shone onto the breast tissue. And over COVID, we've looked at how to stop ladies coming for long periods to a hospital setting. So we've cut down some of the regimes. So some ladies will come for a planning appointment as a one-off, so we can take a sort of a picture of the breast and the chest wall, and then about a week later they start the active treatment. It's only for about 10 minutes a day. And we can do it from Monday to Friday, so we've shortened it down for some women over a week there. Some ladies still need the standard treatment of 15, so that's Monday to Friday over 3 weeks there. And there's different reasons, and we will always explain why they need radiotherapy, or sometimes with trials we can omit radiotherapy now, which is quite new at the minute, but we can explain to the ladies why we're not giving radiotherapy.
Right. And am I right in understanding both chemotherapy and radiotherapy will improve your outcome? So
yes, these are all done as preventions. So these are sort of added insurance policies to the surgery.
Right. And the surgery is the main treatment for breast cancer?
It is.
Usually I would say for the majority of patients.
And the third treatment, bone strengthening?
So these are usually given as tablets, but it can be given as a drip once every 6 months. But most women can tolerate the tablets, so it's a daily tablet. It's a drug called ibandronate, which is a bone strengthener, and it can, some people would know it because it's also used for osteoporosis, but we use a higher dose. And it's been proven that for women who've gone through the menopause and have breast cancer, that it reduces the risk of the cancer coming back and spreading to the bones. So it is an important treatment, but unfortunately it does only work for the ladies who've gone through the menopause. And we don't need to give it for women with a very low risk of cancer coming back, because it would just give them no benefit at all.
Right. Is that a relatively new treatment?
Yes,
Yeah.
it's only 5 years.
Are you still followed up by the hospital after your active treatments for breast cancer?
So what would happen is, once the active treatment's finished, you have a visit with the breast care nurse. The breast care nurse would go through the care, arrange the follow-up, and address any concerns, also give a bit of education. The follow-up schedule then depends on the individual. Most people have a mammogram once a year for the next 5 years. The exception would be if they've had both breasts removed, or in some cases very elderly patients may not get any particular benefit from that. In terms of follow-up appointments, in some cases ladies have a very low risk of further problems and they don't benefit from follow-up appointments, so we don't need to organise any. When we do have follow-up appointments organised, it's to fit around the treatment schedule. So we do appointments at basically 3 and 5 years. At 3 years, many women are stopping the bisphosphonate, which is the tablet for the bones, and also sometimes the hormone tablet, the hormone therapy, is changed. The type of tablet is changed, so we can do that at that point in time if we need to. The other thing that happens is some of the treatments can weaken the bones a little bit. So some women have to have a scan called a DEXA scan to check that they're not developing osteoporosis. So these appointments are really a chance to catch up with a patient and make sure that everything is on track, that they're on the right treatment, and that they're having the right test to monitor them. We don't do tests to look for spread elsewhere because they've not been proven to be of any benefit. And unfortunately the tests have a high level of radiation, so they can cause harm. So we only do tests like that if people have symptoms. Probably most importantly, apart from the mammograms, patients have open access to us, so they can ring up and speak to either a nurse practitioner or a breast care nurse. And if their concern sounds like it might be something that needs an examination, we can arrange for them to have urgent examination. And often we can see patients quicker than they can see their own GP. We do imaging if we need to, and if there is a problem, we'll obviously manage that as we need to. But most women would be reassured if they find a problem.
I've heard there's a programme called the Moving Forward course for ladies that have had breast cancer.
Yeah.
Can you tell me about that, Christina?
Sadly, it's gone on hold a little bit for the face-to-face due to COVID, but as we were saying, when a lady has finished treatment and she may be just on medication, they have an appointment with the breast care nurses. Again, we do like a holistic needs, so we're listening to the concerns of the woman. We'll go over any query about any treatment they might have, so we'll go over what the operation was, the findings from the operation, and explain that, because it's a bit of a brain fog when some ladies are first diagnosed. We'll go through treatments that they had and any side effects, sort of late effects from the treatment there, and just really psychologically catch up with the woman and see how she's coping. And then we'll call, it's a management name, we'll stratify what pathway, so either self-management, or they're going to come back for what we call standard treatment at year 3 and year 5, and arrange all the mammograms. Then we give them a booklet, we like giving pamphlets in our unit, called Moving Forward. So it covers lots of things like fatigue, that your body is recognising your body's changed, the breast is not the same, or the breast is not there, what should I be looking for, what should I report. So there's a booklet about it. We usually do face-to-face, and we tie this in with breast cancer now, and we used to have 15 to 20 ladies, and we had it used to be 3 Friday mornings, and we used to cover about prevention of lymphedema. We did about body awareness, fatigue, about sexuality, because we're talking about menopausal changes and body image issues for some of our women there. And we talked about what complementary services within our local services within Doncaster and Bathurst to encourage women to meet up and to carry on life there. At the moment it's converted to sort of online, and so they can contact breast cancer now, and they'll sort of book them in for little classes, and it's sort of the private of their own house to go on that. But at any point in time we're constantly reinforcing that you ring within that 5 years, you must ring the breast care nurses or the nurse practitioners, or some people have a good relationship with a GP, so we don't discourage that. And even after 5 years we still have some of our old patients will still contact the breast care nurses just to run things past us, and then we'll sort of say what you need to say to the GP, the receptionist, and what we expect will happen.
A few questions that were raised by the focus groups. Yeah.
Well, the first one was when several ladies have said that they're embarrassed to talk about their symptoms. How do you deal with this?
We usually thank them for coming, because it's just recognising that they've got a problem or an issue, and usually we try to sort of, with non-verbals on our body language, sort of try and speak the language of the person, and sometimes we'll try to just gently coax what they're saying, because we're all human, we all have hair in our armpits, we all have funny looking boobs that don't match. We have a nipple that doesn't match the other side, so we're all that's very normal for us, and we can see from the body language of that person, we try to keep dignity, so use gowns and then slowly sort of get the trust of that lady. And from a breast care nurses, we're quite used to talking about sexual things, and we're not shocked at any words people use to explain things, and just to gain that trust and give them that time to explain.
One of the other things that was said, that some of the ladies avoid going for screening and the mammogram because it's painful and uncomfortable. Can you advise on this?
So, with having had mammograms myself, I always tell ladies, you try not to be helpful and allow the technician, the radiographer, to help you into that position. You think you know the position you're meant to be in, but it isn't the same way, and sometimes you have to try, it's not a natural thing, but to relax, and they will guide you into that position. Don't try and help them. You have to go a bit floppy to get them into that position. When they do compress, it can be uncomfortable, but it's a very short sort of time scale there, and they're very understanding how anxious we all are when we go. But just mention that as you go in, for them to recognise that. If some ladies, if they've had a breast cancer treatment in the past, they're very normal to be quite tender when they go back for mammograms. So we usually advise maybe an hour before their appointment to have 2 paracetamols, just to maybe take the edge off. And that could be for ladies that are going through screening if they've got sensitive breasts to start with, to do that. But listen to the radiographer when she's doing it, and move when she asks you to move. Don't try and be helpful and think you know what she's going to say next to you.
Would it be reasonable to say to somebody that didn't have breast cancer, that was just going for a routine screening, it's uncomfortable rather than painful?
Yes.
Is that a more
I think that's
realistic?
I think that's correct.
Yeah.
I think it's also really important that if you start getting severe discomfort or pain, you must say to the radiographer. It's no good not saying anything and then going away, because the radiographer won't be aware that she's caused pain, and nobody wants to cause pain. Our aim is to do this in a way that's painless, because we want women to come back in 3 years' time for the next mammogram. The other thing to say as well is, when we do a mammogram in the breast clinic, sometimes we will intentionally delay the mammogram because we don't think the person's got cancer, we just want to be sure, but the person's got a condition which makes it very painful at that time. So if they've got, say, a breast abscess, we would wait 6 weeks until it's settled. If they've come with breast pain, but say something else and we don't think it's to worry about, again, we might wait till a few weeks after and make sure, so that's right, to get and perhaps make sure they've taken painkillers before they come to the clinic, so that it would be less painful.
So you're trying to avoid that?
We
pain,
are,
aren't you?
Absolutely.
Is there a difference if people have implants? Is there a difference to the way that you do it, to the way that it would feel?
The radiographers are very experienced at doing mammograms of people who've got implants. It's really, really important to say if you have an implant, because some women's breasts, you can't tell there's an implant. It looks very natural, so the radiographer wouldn't know until they've seen the mammogram picture. But in fact, they will position slightly differently in the machine if there's an implant, because they also ideally need to know if the implant is above or underneath the muscle. And if they know that, then they can get the best possible mammogram. Technically, mammograms aren't quite as good when you've got an implant. They're slightly more likely to miss something. But the converse of that is you're more likely to feel something. So it's not dangerous to have implants. They don't cause cancer and they don't increase the risk of a delayed diagnosis of cancer. We just need to know that there's an implant there so we can work around it.
Can I do anything to prevent or minimise the risk of breast cancer.
So this is where all our women's magazines come in. So we know this, and it's putting it into practice. So we know by living a healthy life, so that's diet and exercise, whatever age we are, we can help towards preventing. So it is looking at our metabolism slows down as we get older, so it's looking at portion sizes. We're not saying that you have to go to the gym, but just walking more, increasing the speed you walk a little bit so you're a bit out of breath, just for say 10 minutes. These are very simple things we can all do. We all know this, it's just sometimes we choose, and little and often, so having a chocolate biscuit does no harm, and don't feel guilty about it, but it's just managing your coping mechanisms. If you are feeling a bit low and this is where mindfulness and start to look at other alternatives sort of to help with the psychological things. That has a big impact on our moods, and that sometimes has a knock-on effect with diet and exercise there.
Absolutely. It's about avoiding excess sugar and fat as far as possible, and using things like sugary or fatty treats as treats and not as daily events. The other thing is we should all avoid smoking. It's probably not associated with breast cancer. There's some uncertainty about that, but smoking puts you at increased risk of other health problems and can cause problems when you have treatment for breast cancer if you're a heavy smoker. The other thing is to minimise alcohol intake. So excess alcohol intake has been linked with breast cancer risk. So we should keep within the government recommended limits.
Can males get breast cancer?
Yes, men can get breast cancer. Luckily it's rare. Only about 1 in 100 cancers are in men. In men, breast cancers are usually quite easy to detect. So they present as a hard lump with skin and or nipple change, and sometimes bloody nipple discharge. The commonest cause of problems in men, which requires them to come to the breast clinic though, is something called gynecomastia. So that's not cancerous and it's not linked to cancer. It's just a tender swelling underneath the nipple. There are lots of causes. In some cases it's just age related, so it's common in teenagers and old men. It can also be caused by anabolic steroids that are taken for bodybuilding. It can be caused by taking cannabis or cocaine. And some prescribed medications can cause it as well, particularly medications associated with heart problems and with stomach acid. In most cases there's either no treatment at all or just a change of medication. We don't usually do any tests. Sometimes we do a blood test though, and the blood test is just to double check that there aren't any other hormone problems or problems with things like the thyroid gland that could cause this.
Thank you very much, ladies. That's been incredibly helpful. A lot of valuable information. It's going to be really helpful for us going forward. I can't thank you enough.
Our pleasure.
And again, you know, from all the ladies in Doncaster for the incredibly valuable work you do in the service. We're so fortunate to have such a wonderful breast service in our locality.
Thank you.
Thank you.